A very good evening, everyone. Thank you for joining us tonight for today's webinar masterclass. I think many of you have joined us in the June webinar with Professor Marini. And tonight we are privileged to have Professor Marini back with us again for a more advanced level of the masterclass of the Fotona Pico lasers. And today's masterclass is on the Fotona Starwalker MAQX and PQX. We call this the dynamic duo for pigments, pores, pimples, pits, and more. And just a little heads up before we get started. If you have questions during the presentation, please feel free to type them into the question box in the Zoom control panel. And the questions will be answered during the Q&A session after the presentation. Once again, honored to have us live is Professor Leonardo Marini, a prominent board-certified dermatologist and general surgeon based in Italy. Professor Marini has many years of laser experience and has done many presentations worldwide as well. And tonight, Professor Marini will delve deep into the advanced techniques with these lasers, as well as discuss the deep insights from his case studies on using all 4 laser modalities on the versatile Starwalker system, mainly the MAQX, the Frac3, the Versa3, and the Frac10, into a single combination treatment. We call this the Fotona 4S treatment, 4-step treatment. And also his hidden methodologies behind his exceptional results. And I'm sure he'll be passing us some more additional clinical tips like the last time as well. And without further delay, I would like to pass over the time to Professor Marini. Over to you, Professor Marini. Thank you.
Thank you. Thank you to Cervicom Medical Singapore for organizing this masterclass, Fotona Masterclass. It's a pleasure to be with you once more. And I welcome you all from all over the Orient to attend this masterclass. So without further ado, I'm going to start with my first presentation. When we talk about Q-switch laser is a whole family of technical marvels. Okay, when you see QS laser stands for Q-switch. What is a Q-switch laser? It's a specific emission mode of laser energy, which is possible thanks to a specific cell called pocket cell that makes, the mega impulse, which is possible only if you have this kind of technology. So there is a major distinction between conventional laser and Q-switch laser. Conventional laser, they don't have the magic box. They don't have the pocket cells. So the laser is produced and it's kind of, let's say, organized in millisecond or sub-millisecond, okay, pulse duration. But when you put on the laser system this pocket cell makes the possibility of make a mega pulse which is lasting only in the range of nanosecond or picosecond today. Femtosecond will be the future. So let's go with nanosecond, picosecond. So nanosecond, picoseconds are both Q-switch, and only Q-switch laser can emit this kind of energy. Okay, this must be very clear to you. So when we talk about Q-switch laser and this specific energy interact with biological tissues, we have different photoacoustic conversion cores. With normal laser, conventional laser, you don't have a photoacoustic, you have a photothermal conversion core, because the duration of the interaction between the laser light and the absorbing chromophore or structure within the dermis or the epidermis, it's allowed the temperature which is formed when the energy the light energy is converted to the very point of contact into heat. And according to the pulse duration, you allow this heat, not the light, to travel outside the target to get the clinical results you want to have. This is possible with conventional laser. When we have a Q-switch laser, which are emitting in the nanosecond or picosecond pulse duration, you have the possibility to interact with the same kind of chromophore. Could be melanin, could be water, could be other kind of chromophore like a tattoo pigment. But the duration of the interaction between the light and the absorbing chromophore is so short that the energy is not going to be able to be converted into a traveling temperature. The temperature stays within the target. And when the temperature stays within the target, what happens? The target cannot keep the temperature inside, so it explodes. So we have a kind of photoacoustic effect. And you hear this explosion when you do the procedure on the patients and or any inanimate kind of phantom, for example.
Professor Marini, sorry to interrupt. Are you showing the slides now over here? Because I don't see any slides yet.
I see. Yes, I'm on my second slide. You see my second slides?
No, I don't see the slides over here. Could you try to reshare again? Just one more time.
Let me see. Okay. Sorry. Share again.
Yeah, I can see your computer.
Okay.
Yeah, now I see the slides.
Fantastic. Sorry for this technical issue. So we're going to compensate now. But the concept I try to explain, I hope it's clear. Okay, so my first slide, and now we're going to move to the second slide. So again, now everything is under control. So when Q-switch laser interact with biological tissue, you have the concept of what's happening. So the same rules of light and specific chromophore absorption apply to both conventional emission laser or Q-switch laser. But the Q-switch laser, they have such a short pulse that the energy, when it is converted, doesn't have the time to travel outside the target itself. So it is within the target. So we have this kind of photoacoustic conversion. Okay? So we can have a photoacoustic lysis. Okay, we can destroy the target, like we do, for example, with the selective photothermolysis when you want to coagulate some vessels. Or you can have, in this case, you can see the first treatment with fractat. You heat the chromophores, which are contained in the tattoo ink, and you fragment, you make them explode, you make them, destroy, fragmented in microparticles. Or, and this is when we do 2 passes, we are able to reach even deeper pigment layers, because the fragmentation of the first layer made for the light the possibility to go through this fragmented kind of particles, because these fragmented particles, they don't absorb as they used to be when they were intact. So this is the principle of the fractat. So this is the fragmentation, the destruction of the target. But you can also use have a different kind of laser tissue interaction, which is called a photoacoustic biomodulation. Photoacoustic biomodulation happens when the energy that you are delivering, keeping constant the absorption that you can have with a specific wavelength, is not able or is not there to kill or to make the lesion explode. It makes the lesion vibrate. So with it's a photoacoustic biomodulation. And this is a nice article that maybe I already presented last time we met. So that tells you that in order to get a collagen production, you don't need to have the photothermal effect. You just with the photo acoustic effect, not to destroy the target, but to make them vibrate, you can trigger the production of collagen type 1 and procollagen type 3, both with 532 and 1064. You can also down-regulated the matrix metalloproteinases, which are, it's very important if you want to rejuvenate the tissue. And with this kind of photoacoustic biomodulation, you can also upregulate the tissue inhibitors of the matrix metalloproteinases. So the overall clinical result is a very efficient collagen production, just with the photoacoustic biomodulation. You can also have an excellent production of Hickshot protein 70, which is a very important protein in the rejuvenation effect. Okay? So, these are the photo interaction core. So, according to different wavelengths, we can penetrate through the skin. And in the duo family of the Q-switch laser produced by Fotona, we have the possibility to interact with tissue using the 532 nanometers wavelength, or we have the possibility to interact with the tissue using the 1064 nanometer wavelength. These are fantastic wavelengths. The 532 is green light, and the green light is very much absorbed by melanin, so stays on the surface, doesn't penetrate. So it is an ideal wavelength to work on superficial pigments. The 1064 is absorbed by melanin, not as well as 532, is absorbed by water, and is also absorbed by, of course, the hemoglobin. So all this absorption makes, the specific wavelength, which is longer than 532, is double, as a matter of fact, to go deeper into the tissue. So the photo acoustic core is much deeper within the skin. What happens when we have the absorption? Again, we have a photo disruption, or we have a photoacoustic biomodulation according to the energy we use. So you see very short amounts of pulse. If you want to go to the thermal effect, then you have vaporization, coagulation, photochemical, photobiomodulation. But when you take photobiomodulation and you are in this area of this schematic representation of laser tissue interaction, this is caused by temperature, and this is caused by vibrational effect. So let's go to back to the two brothers here, the MAQX and the PQX. They are both Q-switch laser. They have the MAQX is a platform. Is a platform where we can really have a lot of versatility. We have the super pico pulse using 1064 or 532, using a 580 picosecond pulse in a row. So we can have a very powerful pulse. We can have the frag-free mode. We can have the Versa mode. Frag-free is photothermal. Versa is photothermal. And so we have the possibility to have both the Q-switch photoacoustic mode and the photothermal mode using the two different wavelengths. And they have also the Versa, which is a green light working with longer pulses. Longer pulses means that the interaction with the tissue is photothermal. Okay, so with this MAQX, we have the possibility to have two kinds of interaction with the tissue, photoacoustic and photothermal. Now, let's move to this PQX model. This is the most powerful pure picosecond laser on the market. And to make a single pulse, picosecond pulse, powerful, it is very difficult because you need to concentrate a lot of energy in such a small amount of time, which is 300 picosecond in this case. And so it is not possible to have a large spot, okay, with a very efficient wavelength to disrupt the tissue. But we have the possibility to have excellent photo biomodulation. So if you use the PQX to have a photo acoustic lasers, you can use it with a spot size of 3, maximum 4 milliseconds. If you want to use the PQX for photoacoustic biomodulation, then you use larger pulses like 6 millimeter or 8 millimeter spots, okay? Now, photomechanical or photoacoustic, photothermal. These are the two concepts. Both concepts are possible with the MAQX system. The photomechanical is exclusive to the picosecond system, which is the PQX system. So this was the beginning of the adventure of Fotona in the Q-switch kind of laser category. And this was the original Fotona MAQX, the most powerful nanosecond emitting Q-switch laser on the market. I got a very nice result with this system as well, working in a short nanosecond pulse. Another concept I like you to understand is that then when you talk about nano or picosecond pulse, so this is a family. These are families of energy that are of time delivered energy. So nanosecond we can have short nanosecond, like in this case we got 4 nanosecond emission, but you can also have Q-switch laser operating in nanosecond kind of pulse duration that got 50 nanoseconds. You can imagine that the laser tissue interaction with a longer pulse like 15 nanosecond was different than using a shorter pulse, which was in this case 4 nanosecond. The shorter the pulse duration, the more the photomechanical effect and the less the photothermal effect. Okay, with the picosecond laser, even when we talk about picosecond laser, the family of picosecond lasers is huge. We can have long picosecond laser, like for example 750 picosecond laser, or you can have a short picosecond laser, which are like the PQX by Fotona, which is 300 picosecond laser. The same rule applies. So the shorter the pulse duration, the more affected the photoacoustic effect on the tissue. So, and this is what happening. You have the when you talk about picosecond laser now, with the MAQX working in the picosecond kind of setting, we can have the 580 picosecond proprietary trained pulse, which I call super pico or ultra nano pulse. What does it mean? That using this specific technology, you have a picosecond pulse lasting 580 picosecond, which is intermediate, picosecond, but Fotona was able to combine in a single pulse of 4 nanosecond, 5 peaks of 580 picoseconds. So it's actually, this pulse is a structure pulse, very powerful pulse, because imagine that 5 pulses, picosecond pulses, are better than a single one. So the effect on the tissue is much more intense. With the 300 picosecond, this is a true picosecond pulse, single pulse, 300 picosecond pulse emission. With a new version, you can do you can immediately, automatically organize train of 300 picosecond pulses, like 5 or 10 or 2. Okay, without, when you press, for example, the pedal, when you have the 2. The setting on the 2 consecutive pulses, you have tuck, tuck, 2 pulses of 300 picosecond. Okay. When you talk about 10 picoseconds, 10 pulses, automatically you deal the deeper hole. So the more the amount of stacking that you do with any kind of picosecond laser or any kind of short pulse laser, you go deeper. Okay, and this is very important if you want to dig deeper holes in a fractat mode. This is the Starwalker Mach-UX. This is hybrid pico-pulse train within a nanopulse structure, as I explained you before. So we have 580 picosecond, and we have a 5 nanosecond pulse duration. So in 5 nanosecond, you have this sequence of picosecond pulses, which allow the concentration of picosecond photoacoustic energy in 5 nanosecond, huge and enormous energy. Okay, so this is very important for you to understand. So I call this super picopulse, and the sequence of picopulse explains the white. Then let's move to the PQX. The PQX, you can see here, and there is a comparison with other systems available on the market. You see, concentrate on the pulse duration. So you can see long picosecond pulses, 750 picoseconds is almost 1 nanosecond. This kind of pulse duration creates inevitably some photothermal effect, minimum, but there is. The shorter the pulse duration, like you can see the 300 picosecond, then the minimal photothermal conversion core exists. Just is almost a pure fragmentation or a pure photoacoustic biomodulation effect. Now, 2 game changer and 2 a milestone in picosecond lasers. 1, the advanced picosecond laser technology I told you about, and the fractional Q-switch laser beam delivery. That in the past was not even possible. Let's see an example of what we can attain just varying the pulse duration of picosecond laser. These are 2 identical tattoos, same color, same artist, same symmetrical anatomical location, very interesting case. And I decided to treat these 2 tattoos with the fractat technique using the super pico, okay, which is the Mach-UX on one side, and the pure single pulse picosecond laser. So, and see what's happened. That's after 3 procedures, you can see that the area treated with the picosecond pulse, the pure picosecond pulse, 300 picosecond, clear a little bit better than the long pulse, the train of 580 picosecond pulses. That means that the fragmentation of the pigment was more efficient with the short pulse. See what's happened? This is the picosecond side. This is the fractional pico. Okay, you can see very clear little holes. And in this case, we used a train of 10 subsequent picosecond pulses to go deeper. You can see an immediate bleedings, and it means that we reach immediately the deep reticular dermis. And then this is after a full beam picosecond. That's it is. You can see the white is discoloration due to the photoacoustic effect on water. And thanks to the fact that we pre-drill the skin with these micro holes, the gas bubble that are formed when you use a full beam kind of laser tissue interaction, the gas bubbles get through the holes, and so we don't need to wait as the original proposed paper called R20 repetition every 20 minutes, and we needed to wait 20 minutes after each full beam laser Q-switch laser pulse in order for the gas to be cleared and to see the tattoo again, but we need to wait just 5 minutes, thanks to the fact that we are able to get the gas bubble escape outside. This is the this is the super pico pulse. You can see the different quality of the holes. In this case, the holes are a little bit more let's say less precise. We have a little bit of more photothermal effect maybe, which is due to the relatively longer pulse duration. This is the clinical result after one fractal session. You can see the two system, very minimal, effect after the first, but just immediately after the second one, you can see the picosecond area, the picosecond treated area has been much more successful than the train of 580 picosecond pulse laser. Fotona nanosecond and picosecond can be also used in a fractional ablative mode. And this is quite a revolution. So we can use the 1064 wavelength, which is not a surgical wavelength, but thanks to the fact that this specific wavelength, as I told you before, is able to interact with water, with melanin, and with hemoglobin. Every time we hit with high energy a small area, we are able to have a photoacoustic disruption of the tissue. And if we stack pulses, we can dig holes within the tissue using the specific wavelength 1064. So we are not using erbium YAG, we are not using CO2, we are using 1064. And we can have 9 by 9 millimeters with the Fotona technology, or you can have the 5 by 5 millimeters. So, of course, imagine that the laser beam arrives to the handpieces here. In the handpieces, what's happened in the handpieces in order to produce this kind of fragmentation of the full beam? We have a specific crystals inside. So if this area of the distribution of the pixel we are able to produce through the crystal is 9 by 9, what does it mean? It means that we are diluting the energy that arrives here in an area which is 9 by 9 millimeter. So we have the energy which is going to be less than if we dilute the energy in a 5 by 5 millimeter. This energy is much more concentrated, so these holes are going to be much more deeper when we stack pulses. So this is an ideal handpiece to do a fractional photoacoustic rejuvenation, because we are able to treat larger area faster. And this 5 by 5, since it's much more concentrated in terms of energy, we can use this for dealing with scars or dealing with the fractal technique to eliminate tattoos. So this goes deeper, this goes more superficial. How can you explain that using the 1064 wavelength, we can dig holes? So every time a wavelength interacts with tissue, okay, we have in the initiation of not a photothermal effect, but a photoacoustic effect. We have the propagation of the photoacoustic effect, and this propagation is proportional to the number of stacking pulses off to the energy. And then we have the photoacoustic injury of the tissue, periphery of the tissue, okay? The more pulses we do, the deeper you go, and the more photoacoustic injury at the periphery of the holes can happen, okay? So, nano versus pico, okay. So, if you use for example, a photothermal, nanosecond pulse, which is still belonging to the Q-switch mode of emission, we have the photoacoustic disruption. We have also a little bit of temperature, which is produced by the fact that nanosecond Q-switch pulses, they are short, but not as short not to allow a minimal thermal damage to the peripheral tissue. But when we move from this technology to the two brothers here, we have a picosecond pulse, which is much shorter than the nanosecond pulse, so that the photothermal injury zone is minimal, and the photoacoustic injury zone is much more efficient. This is an article that I recently published last year about the micro drilling effect and the refractat. You can see that this is the micro drilling. This is the first pass. This is the second pass of full beam, and this is the healing phase, and this is the final results of the refractat technique on a monochromatic tattoo. So excellent results. This is another example of using the Starwalker PQX refractat technique in a delicate area like the volar aspect of the forearm, lower third. And you can see we had some micro scarring due to the fact that the tattoo artist used the needle to insert the ink quite often and quite intensely. You can see here, you need to point out to the patient this kind of structure changes before removing the tattoo, and this is the end result. You can see we were able not only to eliminate the tattoo, but also to flatten the skin and make the skin almost normal. This is, for example, another example of the PQX refractat. And this is a lady that got a facelift. The facelift scar cut a previously located tattoo in half and said, listen, this is not very nice to see this kind of residual tattoo. Let's eliminate this tattoo. And this is a nice result. You can see the facelift scar here, and the tattoo is completely disappeared. Look at the quality of the skin. The skin is perfect. No scar at all. Then some patient, they want to eliminate just part of the tattoo. And you can see that thanks to the precision of the picosecond, Fotona Pico laser, we were able to eliminate all the part of the tattoo that the lady or the patient didn't consider more appealing. We can use the Starwalker PQS refractat procedure on the eyebrow when, for example, the patient not satisfied by this aesthetic appearance after this kind of correction. And you can see we are able to eliminate most of the tattoo without affecting the hair shaft or the hair follicles of the specific delicate area, because the pulse duration is very short. This is for you a recap of what is the refractat technique to eliminate deeply located pigments. What kind of fraction end piece we use? A 5x5. Don't be misled by the 9x9. This is just a picture, but you need to use the 5x5 photoacoustic fractional vertical tattoo pigment removal to reach the deeper layer where the pigments are distributed, okay? And this is usually using a MACUX, the primary we use. And this is stack false, stack 5 times or stack 10 times. And we use this kind of energy. Then we use the laser-assisted photoacoustic fragmentation of the pigment using a full beam. Okay, the full beam is using a 3 or 4 millimeters. Sorry for this question mark. I don't know why they come here, but they shouldn't be here. So we use the 3-4 millimeter because we want to have enough concentration of power to get to the point of fragmenting efficiently the pigments and the particles of the pigments. Then in between passes, we use a 4 degrees chill compressors in between laser passes in order to cool down, to diminish the hemorrhage that we produce due to the micro holes. And every time you do a full beam pass on micro hole tissue, we, thanks to the vibrational effect, you reactivate minimal bleeding. So we need to wait for the minimal bleeding to be completely reabsorbed. And then, of course, we wait 5 minutes, and in 5 minutes, it is enough. Then when we finish the procedure, this is the typical dressing we use. We use a non-sticky gauze, sterile gauze, paraffin gauze. We use this Flaminal Forte, which is a alginate gel. Excellent. It's not an antibiotic. It's not an anti-inflammatory. It's just an alginate gel. produced by a company in Belgium. You can see this is the consistency, and you just distribute this amount on top of the paraffin gauze. And you may argue, how come you distribute this on top and not directly on the tattoo surface? Because with this, you are able to distribute more evenly, because this kind of product will be trapped in between these little checks, okay? And then it won't slide over. And this is, you see, fantastic way to get a uniform distribution of the products. Then on top, we put a alginate compress. The alginate compress is very important to absorb the oozing that usually happens after the procedure. Then we use a cellulose absorbing pad, and then we use a kind of tubular gauze on top. We change the dressing twice a day until the oozing is completely gone. Then, of course, when we are satisfied, usually after 5 days, 6 days, we start to apply the specific primary dressing, which, of course, it is a not an alginate, but it is a extra thin hydrocolloid primary.
Prof Marini, I think you accidentally muted yourself. Prof Marini, I think you accidentally muted yourself. You're on mute.
Okay, sorry. Thank you. So then we move to the third part. The third part of the dressing is to prevent post-inflammatory hyperpigmentation and to optimize the healing process. In this case, what we use clobetasol, 0.05% cream or ointment twice a day for 2 or 3 consecutive days per week, and Cicaplast Balm V5 twice a day the rest of the days. Okay, and we continue with this kind of topical regime until the following laser session. Sorry. Okay. Then we move to this resistant professional tattoo. Sometimes you have patients that have been treated several times with different kind of modalities, with different kind of laser, and they have this kind of residual, deeply located pigment, which are covered with the scarring system, scars. So this is a resistant tattoo after 14 different procedures. Using the fractal procedure, like you see, micro drilling, followed by a full beam, 2 passes of full beam laser, you can have this kind of results. So we can move from this to this 60 days after 6 fractal procedure. Okay, another example of the fractat for resistant tattoos. Look at the scarring that this tattoo has, and then you have this kind of results. Of course, the treatment is in progress, but this is the only possibility to deal with scars and pigment at the same time. Another case, of course, we cannot do much for the hypopigmentation that was there, but look at the quality of the skin after the fractal procedure. We can use the same approach when we deal with nevus of Ota. And this approach is much more effective than using the Q-switch laser alone. And you can see this is 3 months after 3 fractal procedure on these patients. Okay, how can we produce this kind of fragmentation, micropixel, out of the beam that originate from the laser? We have specific lenses which are inserted in the handpieces. So we have MLA, micro lens array, that can transmit multiple wavelengths, and there is no need to change optic coupler during multi-wavelength treatment, but we have a need to keep a spot diameter small, 1 to 3 millimeters, usually 3 millimeters, to reduce the laser dishomogeneity to a minimum. And then we have a diffractive optical element that can operate with specific single wavelength. So we need to change optics to coupler according to the laser wavelength, because in order, every crystal needs to distribute perfectly and more uniformly the laser beam that goes through the handpiece. So we have an excellent beam homogeneity with all spot diameters, providing that we have the specific kind of crystals in the handpiece. Now, let me move on. What is a new way to work with this Q-switch laser, which is the LIOB, laser-induced optical breakdown. So when we have a focus handpiece, and remember, focus handpieces, the handpieces can be focused or can be collimated. So this exercise can be possible only with focus handpieces. What a focus handpiece means, that the laser beam is emitted from the handpiece and has a focal distance where the maximum concentration energy exists. Okay, if you allow the focus to go under the skin, it means that on the surface you don't have the same concentration of energy that you have under the skin, where the maximum conversion of the laser beam is. So we can be more active under the skin than on the surface of the skin. So be careful that this specific laser tissue interaction can be possible only with focus handpieces. With collimated handpieces, no matter how far you go from the surface, the laser beam is usually, at least if you keep it between 5 and 8 centimeters, is always the same. So it's not possible to have this kind of things with a collimated handpiece. So this is one of the original articles that shows that the most important laser tissue interaction happens under the skin, and the surface of the skin is almost intact, because the energy is diluted here, is more concentrated here. Okay, using what energy, what wavelength? 1064, which is our 360 energy. Because we can deal with many, many different targets with this very versatile. Once, you know, at the beginning of the laser adventure, 1064 was not considered a very good wavelength because we didn't have the specific target, but now it's one of the most used because we know how to use it. Okay, so you see what happened? This is where we concentrate the energy under the skin, and this is the ideal. Okay, it's a focus handpiece on the surface. We have the maximum energy on the surface. If we concentrate the energy under the skin, according to the spacer we use, we can have a energy delivered at -1, -2, -3, -4 millimeter. So the deeper you go, the minimal effect you have on the surface, because the energy is very much diluted here, more concentrated there. You can also defocus. Okay, if you withdraw the handpiece from the skin, you have a kind of superficial distribution of the wavelength, and you can have a kind of photoacoustic peel. Let's analyze the focus spacers we have, the focus handpieces, the black f5 and the black f9. So f9 is 9 by 9 millimeters, and the f5 is a 5 by 5. So are you surprised that using a spacer, the focusing the handpiece at -4 millimeter with the black 5, it's getting deeper than the -4 millimeter using the black f9, which is covering a surface area of 9 by 9 millimeters? Are you surprised about that? You shouldn't, because you know, the energy here is diluted because the area that the laser beam is covering is much larger. So the larger the area, the less the energy which is distributed in the area. The smaller the area, the higher the energy, so you go deeper. So 5 by 5 concentrate more energy, so you go deeper, and the 9 by 9 concentrate more energy on the surface of the skin. This is a nice example of what you can obtain with a this is black 9 by 9. This is the focus is on the surface of the skin. So you see all the little holes creating by the focus handpiece on the surface of the skin. When you focus with -1 millimeter, you still have some disruption, photoacoustic disruption of the surface. But if you use the -4 millimeter, minimal kind of effect on the surface, and most of the effects are under the skin. This is very important when we are going to deal with the phototype, skin type, phototype, photogenetic type, like the Oriental skin, for example. The gentle touch of Star Walker PQX. You can see this is a solar indigenous, and this is 5 minutes after 532 nanometer laser passes using the 300 picosecond pulse. Okay, another example. Okay, very gentle. And this is the typical effect of the 300 picosecond, as is a typical effect of a super pico, which is a train of 580 picosecond in 5 nanosecond pulse duration. So we have a much more evident purpura. Okay, why do we have that? Because we have delay purpura, very discrete. We have more evident because the energy here on the PQX is able to fragment with the vibration effect some of the capillaries that are in the papillary dermis. When it comes to the aesthetic scenario, you know that present trend favor minimally invasive rejuvenation procedure. Modern Q-switch, remember, as a family, nanosecond, picosecond laser are valid options, as I explained you before, as standalone or in combination with other treatments. Okay, very versatile. This is a nice example of a standalone results using the sequence of 1064 532 in a photoacoustic biomodulation mode. You see the energy is small, you see the spot size is big, so we don't concentrate much energy, but we have a photoacoustic vibrational effect in the within the tissue, and this is enough to stimulate collagen. This is a Q-switch 300 picosecond pulse skin rejuvenation, and you can see this called the Frac Renova, using this kind of parameters: 1064, 8 millimeter spot, 1 joule per centimeter square, 10 hertz painting, 3 passes, then 532, 300 picosecond pulse, 8 millimeter, very diluted, very gentle. Look at the energy we use, minimal, 1-2 passes, and then we use a 1064 Q-switch 300 pico pulse, 9 by 9 microablative fractional. Okay, in this case, if you have, for example, a Oriental skin, you can use an LIOB mode with 9 by 9 with focusing -2, -3, or -4. This is again the same kind of short pulse, 300 picosecond pulse. This is immediately before. This is immediately after. You see the minimal bleeding due to the fact that we were using a 9 by 9 fractional mode, last pass of the Frac Renova. This is 2 hours pulse. This is 1 day pulse. This is 2 days, and this is 3 days. You can see that the patient actually the following day can be seen outside and can be engaged in social activity. This is a Q-switch 300 picosecond pulse fracture nova, 4 or 5 session using these parameters, and you can see, look at the quality, look at the of the skin, much smoother, the pores are minimal, and the color is much lighter. In this case, we use a Renova LIOB because we want it to be safer. The patient is a little bit darker in color, and you can see the quality of the skin we were able to obtain just after this kind of procedure. Okay, very, very nice. The neck can be treated with the same kind of sequence. And then when we move to melasma, melasma, as you know, is a difficult scenario to deal with. It affects up to 40% of individuals, mostly females, but not only females. We have 5 main pathomechanisms of melasma. We have an abnormal functional activation of melanocytes. We have an abnormal localized aggregation of melanin and melanosomes with the dermal and epidermal layers. So this can be easily eliminated with the Q-switch laser. Solar elastosis and localized increase of mast cell counts because we have a kind of minimal inflammatory alteration. We have a dermal-epidermal junction functional alteration, and we have also an increased localized vascularization. All these are there in a melasma patient. So being the pathophysiology of melasma multifactorial, it is impossible to identify a single therapeutic strategy able to effectively and durably treat this commonly detected benign pigmented skin disorder. So the recurrence rate is quite high, and the best option is always combining treatments and tailoring this combination treatment to each of the patients. To summarize, okay, melasma, we have the accumulation of melanosomes, we have the dermal-epidermal junction kind of alteration, we have mast cells degranulation, so we have an inflammatory process, and then we have also a vasoreactivity due to the fact that we have vascular endothelial growth factor, transforming growth factor beta. So we have the vascular component, we have the inflammatory component with the melanocytic component, and we have the microanatomical component. So all these need to be addressed. So UV radiation, hormones, genetic factors can act on the keratinocytes, fibroblasts, okay, and melanocytes, and of course the vascular endothelium, okay? What happens when we expose the skin to different natural occurring wavelength? So with visible light also trigger, a deeper, it's a much more deeply penetrating wavelength. So we can have affect the outer basement membrane. We can affect the fibroblast. With UVA, we can go to the melanocytes. We can even reach the endothelial cells. And with UVB, of course, we are able to trigger the melanocytic activity. All these need to be not blocked but filtered in order to have a nice result. So the 2 brothers from Colombia, the Julio Cesar and Sebastian Velez, they came up with a formula using the Q-switch laser, and this specific kind of sequence can be also used in oriental skin to deal with pigmentary and textural changes, and this is known as Fotona 4S. So the first step is the Q-switch and the YAG pulses with the short pulse to deal with the melanosomes. The second step, using low fluence, short frag-free, and if you use the Star Walker MAC-UX, you have the possibility to have also this modality. Then the third step, you use the FracTac technology. You can use the LIOB in your skin type, oriented skin type, or you can use a fractional focusing on the surface to do this kind of stimulation of the keratinocytes which is very important to have a paracrony effect with the deeply located fibroblasts. And then in case you have some vessels available, then you use the 1064 with the Versa mode to coagulate the vessel. Combination strategy. Okay, this is a nice effect using a chemical peel after the fracture. Even the most advanced laser system, even if you are an expert, you should be an expert, but you must be careful. If you use the wrong parameters and improper clinical indication, you end up with this kind of complication. Look at the setting that was used in this case to treat a melasma. And this gentleman, this colleague, was so brave to treat a post-inflammatory hyperpigmentation using these parameters. And of course, he made a mistake. So be careful. We have a very potent kind of system in your hands. You need to use it properly. This is, again, if you use high fluence 1064 Q switch, you can trigger a peripheral post-inflammatory hyperpigmentation and worsen, melasma. So you need to be gentle. So remember that when you are dealing with the epidermis and you are creating some micro alteration on the keratinocytes, so we trigger a repair process. Newly formed epidermis usually require considerable time before reaching a complete recovery of the skin barrier. According to this paper, up to 2 months after the skin injury. So you need to be gentle when you do multiple procedures. You need to understand that the skin is still in a repair process. Okay, very important for you to schedule the subsequent laser treatment appropriately. So the aims of the late skin care is to protect newly formed epidermis, is to enhance the skin barrier function of newly formed baby skin tissue, control the postoperative procedure erythema and prevent melasma reactivation, and prolong, of course, the beneficial effect produced by the dermatology procedure, like the one proposed by the 4S, for example. In this case, we treated this patient affected by melasma with the proper parameters, and then we use a system in a long, let's say, topical treatment to keep the result with this kind of effectiveness. This is a sequential multi-step laser protocol for rosacea. Look at the skin reactivity here, and look where we were able to diminish quite consistently the reactivity of the skin working with this kind of parameter. This is a Fracmanova R, the stage for rosacea. Again, 1064 full beam MACUX, 8 mm photoacoustic biomodulation, using, in this case, the MACUX. The second step, full beam frac free, okay, and this is photothermal photobiomodulation on these small vessels. Then fractional beam LIOB minus 3 mm fractional, and then the fractional beam on surface of the skin in order to have double stimulation of the keratinocytes. And this is the before and after, and this is before and after. Present trend favors, as I said before, combination treatments, and this is a décolleté treated 5 minutes after 532 spot by spot photoacoustic passes. You already recognize what kind of laser I'm used here. I used the Fotona Starwalker MACUX, not the PQX. This is 10 days after Q switch fractional photo peel, and then on top we use a 15% TCA ultra fast chemical peel. Look at the end result. Don't look at this hypertrophy scarring. We did the biopsy on this lesion, and she developed this hypertrophy scarring, but we are dealing with this now. So, but look at the quality of the skin from here to here in a single procedure. On the hands, we can do the same. Okay, we're using this procedure. And then you can use an advanced fractional Q switch picosecond photopeel. So using the Fracmanova parameters, and you can apply a TCA, 15% chemical peel on top, which much better results as using just the single laser. You can see before and after, just in a single laser procedure. Hands, the same, okay, using this kind of combination. We know that advanced preventive and curative photodynamic procedure are showing extremely promising results. And this is what I call a thermofractional PDT. This is a catalog of skin lesions on this patient. We have skin sagging, we have solar antigens, we have actinic keratosis, and this is immediately after the procedure. This is 10 days after, and this is 1 month after the procedure. Look at the quality of the skin after a single procedure. And this is leaving the photo, the 5-ala, 3 hours on the patients. The same results on the different patients. And why not combining the Q-switch picosecond laser and the PDT? And this is what we did on this patient. This before and after with 0.5% 5-ala. And this is the 0.5% 5-ala, 30 minutes incubation time. Look at the nice result we can have in a single procedure. The same gentleman on the scalp. Okay, preventive and curative PDT. This is the same, and another patient. The redness you can see is directly proportional to the number of alter cells that the patient has. But look at the quality of the skin after a single procedure using the combination technique. Look, nice quality of the skin. Another patient with the Q-switch Frac Renova PDT. The same patients. Now, can we use the small beam photoacoustic disruption of the tissue to deal with xanthelasma with the photoacoustic mode? Yes, we can. And this is the result you can have with the photoacoustic mode 1064. This is a nice result we can have on a sebaceous nevus, okay, using the photoacoustic mode. And then, of course, we can also use this Star Walker Mach UX FAC3 1.6 millisecond and fractional mode to deal with scars. And you can see, in this case, we did a combination of Q-switch and pulse-day laser, and you can see the results. Another, this is a hypertrophic scarring, fantastic result. This is a keloid, very difficult, but with combination, we can have good results as well. Another keloid surgery and control. And with this, I conclude my presentation. I hope you like it, and I'm here to answer all your questions.
Thank you, Professor Marini, for the very insightful and wonderful presentation. And right now, as promised, we'll be going ahead to take the questions from the attendees. So just a reminder to type your questions into the Q&A control panel. Okay, let's take a look at some of the questions.
Can you please excuse me for just a second? I come back. One
Sure,
second.
sure. No problem, no problem. Yeah. So to the attendees, please feel free to type in your questions right now. Thank you for the questions. Keep them coming in.
I'm back.
Okay, welcome back, Professor Marini. Yeah, so we already have a few questions. I think I just start with the first one. In general, you spoke quite a bit about melasma, so it's a question on melasma, and as you know, melasma is a very popular, in-demand indication in Singapore, especially near the equator. Generally, how many sessions do you need to treat melasma, like on average, with the PQX or the MAQX, the Star Walker MAQX?
Okay, this is a very important question. We cannot standardize the treatment. We can standardize the procedure, and we can modulate the energy according to the different kind of concentration of pigment in different patients, but never promise, that to have a results in 3, 4, 5 sessions. So you need to see the patient on a regular basis, inform the patient about the importance of using the topical treatments, which are a adjunct to the laser. Is not that you have a magic wound that you can treat melasma without any problem. You have an opportunity to use a specific technology to be more successful in combination treatments. So you can see the patient. Usually I evaluate the patient after 2 or 3 procedures, and I perform the procedure every 15 days, okay? 15, 20 days, in order for the procedure, skin to be recovered. After the 3 procedure, and we monitor, and I suggest everybody of you dealing with melasma to have a standardized photographic equipment, because you need to have the patient picture before the treatment and after each treatment, so you can share with the patient the improvement. Patient tends to forget, okay, what they had. So when we see that there is a progression in the clearing of the pigments, then we proceed. If we don't see any more progression with the laser, then we stop with laser and we continue with other things, okay?
Thank you. Next question. Yes, this is regards to PQX, I believe, and for the F5 fractional handpiece, what are the fractal F5 energy settings that you use for tattoo and the nevus of Ota?
Okay, tattoos and nevus of Ota, we use the same energy because the pigment is located in the nevus of Ota, is a deep pigment. So we need to use a fractional handpiece, which is going deeper. So what kind of fractional handpiece goes deep? The 5x5. So you need to have a 5x5 to concentrate more energy in a small area. And then if you use the PQX, which is the pure 300 picosecond laser, which is purely photoacoustic, we use a train of 10 pulses, one on top of the other, okay? And this can be set on the screen. You can go 0.5 hertz, because of course you need to pump a lot of energy, and you go to the maximum amount of energy allowed by the system. And you do this kind of covering of all the nevus of Ota. The same thing apply to tattoos. When the tattoo is located in a very thin area, for example, the tattoo is located on the volar aspect of the forearm, or is located on the, let's say, eyebrow, you don't need to go that deep. So in that case, you go with 6 instead of 10, because the number of stacking pulses is directly proportional to the depth of the effect, photoacoustic effect. So in a very thin skin, you can go with, let's say, stacking 5 or 6. If you go with nivos of water, try with 10, or in a young individual, you can go 6 or 5, okay?
And the next question is, what are the F5 and F9 energy settings for -1 mm, -2 mm, -3 mm, and -4 mm? I think you were mentioning about the depth.
Yes, the LIOB. We're talking LIOB. LIOB can be, again, single or a train. Okay, if you want to be more aggressive under the skin, you can use a train of pulses, for example, 2 pulses or 4 pulses, 5 pulses, okay? And this, according to the photo effect or photoacoustic effect you want to obtain, maybe you want to rejuvenate the skin more aggressively, instead of using a single, PQX pulse, you can go a train of 4 or 5, okay? And the setting, of course, is usually is the maximum available, okay, which is not maximum available. It is usually with 1064, it is 6 joules per centimeter square. 6 to 8 joules.
Okay. Yeah. Next question is on lentigens. For lentigens, do you use the 1064 wavelength with a 3 mm or a 4 mm spot size? So there's another way of treating lentigens by 1064. If you do so, do you use the 3 mm or 4 mm? And if so, what are the energy settings?
Okay. We have to make a distinction if you use the PQX or the MAQX. With the PQX, the fragmentation is much more energetic, okay? And if you use a focus handpiece, I suggest you to use with the PQX 3 millimeters, with the MAQX 4 millimeters. Q switch, the wavelength we use in our skin type is 532. But in your skin type, you must be very careful with the 532 because the absorption of your skin is much more intense with this kind of wavelength. Yeah. So in this case, I suggest you to do just the 1064. Okay, and with the 1064, with the PQX, you can go to 3 joule per centimeter square, maximum 4, but do a test spot with the 3 millimeter. With the MAQX, then of course, again, you need to go a little bit higher. You can go to, again, 4 to 5, but do a test spot, okay? Always with 3 millimeters. If you know that when you talk about the solar lentiginous, it's a specific kind of skin alteration where the melanocytes are more numerous in a certain area. Okay, this is not only the pigment, it's the number of melanocytes. If you use the LIOB technique, 1064, you can affect the melanocytes a little bit better. So you can go to -2, and you get even to the deeply located melanocytes. In this case, with the 1064 -2, I like to do a stack 2 with the PQX, for example, and with the energy of 5 to 6.
I see. Okay. So you mentioned stacking. So with the 1064, you do some stacking?
Yes. With the 1064, I use the energy setting that can be, according to the intensity of the pigment, from 4 to 6 with the MAQX. On the PQX, I can go to 2, 3 to 4 with the 1064. If you are there to use the 532 on your skin type, I don't suggest you go beyond 0.7 to 1 joule per centimeter square with the 532 and do a test spot. You can, in certain cases, in resistant cases, you can do both an LIOB 1064 and on top, you can do a focus 1064.
Okay. Okay, this is another question on pigment and melasma. How do we adjust the settings for darker skin individuals in treating pigment and melasma? How if you were to encounter darker skin types? Is there like a common rule whereby you would adjust your settings? How do you do that?
The darker skin, they have a natural filter. So the natural filter is located on the surface of the skin. And there is an inevitable photoacoustic conversion core, which is not where we want it. So you need to be very careful. So the darker skin, the larger the spot to dilute and the lower the energy. Okay, so usually with the PQX, I go maximum with 1 joule per centimeter square, or even less with the PQX with 8 millimeters. Okay, with the MAQX, I can go maximum 1.2, 1.4 joule per centimeter square with the 8 millimeters. Okay, spot. But it is always important to do a test spot. A test spot in a not visible area, it's in getting you some information. If you have an immediate whitening, or if you have a kind of an immediate change, this is wrong. Too much energy. So the end point should be an almost inadvertent effect. So, and I suggest you, if you want to be more superficial, since the 1064 is absorbed very well by water, you can use a spring thermal water spray. So, are you familiar with the famous carbon peel?
Yeah, carbon.
Yes.
Yes.
Okay, carbon peel is you paint the skin with a dark color, and then you use a 1064 wavelength Q switch to do the peeling.
Yeah.
So you stay on the surface.
Yeah.
Okay, if you let's say, spray some spring thermal water on the surface of the skin, the absorption of the 1064 is more on the surface.
Okay. Oh.
Okay, so you can be more gentler on the darker skin and using more energy. So you will see that when you do the passes with the laser, the water kind of disappear because the temperature make the water vaporize. So we do the same with the erbium YAG laser when we use the long pulse smooth beam mode. So we increase the water on the surface in order to have the photothermal conversion core on the surface without affecting the water which is contained in the cells and in the tissue, because every skin has 3 containers for the water. One is the free water that stays on top. The other is the water which is contained into the cells, which is intercellular water. And the other is the water that it is in the extracellular space, in the dermis. Okay? If you don't pre-treat the skin with the water, you immediately vaporize or eliminate the free water. And then you work on the intracellular and intra and extracellular water, which is in the tissue. Okay, you're more aggressive. But if you want to work with just with temperature, you spray some spring thermal water and you use erbium YAG laser, and you just work with the water, with the photothermal conversion core on the surface. You don't affect the water contained in the cells, and you don't affect the water contained in the tissue. You just work with temperature. So this is a new concept, okay? But I cited the carbon peel, which is almost the same trick that you use, to fool the laser wavelength in order to limit the absorption and the photoacoustic mode on the surface, using the 1064 instead of using the 532.
Okay. Following that, another question on quick question on melasma. Do you use the PQX F9 handpiece or F5 for melasma with the PQX? F9 or F5? And if so, what are the usual energy settings?
For melasma, I always use F9.
Okay.
Because you don't need to have a much concentration of energy in a short area, because the control of this energy can be problematic with 5x5. So with the 9x9, you dilute the energy. You can do the LIOB mode, and this is the way to go. And the energy we use is usually 1.5, 1.2, 1.6 joule per centimeter square.
Okay. Another question. Yeah. Could you share? I think you shared one personal experience that you share is on preventing PIH. You have an anti-PIH protocol post laser. Could you share it once again for our audience?
Yes. Okay, our common friend Warapon Manuskiati from Thailand some years ago published a very nice article about the strategy to control post-inflammatory hyperpigmentation after a erbium YAG laser resurfacing. Okay, he mentioned that if you use a 0.05% clobetasol, which is the class 1 more powerful steroid, immediately after the procedure, and you use it twice a day, 2 consecutive days per week for 1 month, you are able to lower the post-inflammatory hyperpigmentation quite a bit. So down to even 40% from the original hyperpigmentation. Now, if the skin is not that much damaged, sun damage, usually you have this kind of skin because you are much more naturally protected. One thing I am using to prevent post-inflammatory hyperpigmentation is when the skin, the epidermis is completely healed, I'm using imiquimod. So yes, imiquimod is a drug which is usually prescribed to treat skin cancer or to treat warts, okay? But it has a very nice anti-neoangiogenic effect. So clobetasol twice a day, 2 consecutive days per week, and imiquimod at bedtime only, a very thin layer, always followed by a moisturizing cream. So these two effects, the two drugs act synergistically. One, clobetasol has 2 effects, anti-inflammatory and anti-neoangiogenic. And imiquimod is pure anti-neoangiogenic. We cannot use the clobetasol longer than 2, maximum 3 days in a row, because otherwise then we create a kind of hypertrophic effect on the skin. So maximum 2 or 3 consecutive days. The Imiquimod is a kind of innovation. I suggest you to try, and you only at bedtime for 4 days. So 2 days clobazole, 4 days Imiquimod. In the morning, always 50 plus SPF, sun protection and moisturization is a must. How long can you continue with this? Usually 1 month. And if the PIH is not completely gone, still persisting, I continue for 2 months.
Okay, I remember one of our attendees remember back in June for your webinar, you also mentioned that you use a mist spray to help prevent PIH. A moisture mist spray?
Yes. To prevent hyperpigmentation, post-inflammatory pigmentation, you need to create a reconstitution of the epidermal barrier as soon as possible. So every time you have a micro disruption of the epidermis, the environment can penetrate and can trigger a response, an inflammatory response.
Yeah.
So moisturization is fantastically working well with the concerning the PIH prevention. We use routinely spring thermal water before the moisturizing cream. Why? Because the skin has a transepidermal water loss, which is normal when the skin is intact. But imagine when you micro damage the epidermis, the transepidermal water loss is much more advanced, and so the skin dries faster. When the skin dries, then of course the barrier is not working properly, and then the inflammatory process lasts longer. So post-inflammatory hyperpigmentation, inflammatory needs to be let's say, keep under control by moisturization. So spring thermal water immediately before the moisturizer. Don't allow the spring thermal water to get dry. So spray and immediately tell the patient to put the moisturizer cream on top. Okay, this so you trap the water in the corneal layer.
Okay, fantastic. Thank you. And one more question. You shared about the 4 steps or the Fotona 4S, to treat like overall rejuvenation or even melasma. Are you, for Asian skin, do you recommend that we can do all 4 steps together on the same session, or maybe we split up the steps for Asian skin?
You need to evaluate every patient.
Okay.
Every patient different. Again, to answer this question, we cannot standardize. In theory, we can use the 4 different steps in a single patient if the patient has a fair skin, is not that dark, and the melasma is not that active. Okay, but if the melasma is active, the patient is inflamed, maybe the patient suffer from underlying kind of problems. So I like to do 3 steps instead of 4.
I see.
And maybe the last step with LIOB instead of using the fractional, focusing on the surface of the skin.
Okay, fantastic. Yes. Okay. Any more questions from the floor? For Prof Marini? We just wait a couple more seconds for any final questions over here. Okay, just one more question. You spoke quite a bit on lentiginous or solar lentiginous, some with the 1064, some with the 532. We do encounter some very light colored or very fair solar lentiginous in our population. What would be the best method to treat those very light colored solar lentiginous?
With the light color, so it depends on the background skin color. Because
Okay.
if the background skin color is kind of reactive and pigment, look at the palm of the hands
Okay.
and look at the creases. Okay. If the creases are kind of darker and they are kind of, let's say, brownish, it means that this patient is prone to develop post-inflammatory hyperpigmentation. Okay, so this is why, because we are using the hands, we are open and close, and these are the wrinkles where the skin is kind of triggered to a mechanical stress. Mechanical stress is also inflammatory in some cases. And if you have a darker brownish line, this is a sign of patient that can develop post-inflammatory hyperpigmentation. Okay, so this is simple, just to point out to the patient. So coming back to your question on the light skin, if they are so light, a solar lentiginous again is a combination of an enhanced number of melanocytes which are producing more melanosomes. So it is not be full, but this kind of superficial and light color. You can trigger a darkening of this solar lentiginous if you are too aggressive. Okay, because the population of the melanocytes there is more numerous. So in my experience, what I use a very gentle 532, very gentle, which is usually 0.7 joule per centimeter square with the PQX, or maximum of 1 joule per centimeter square with the MAQX, and yes, and full beam. And at the same time, before doing that, I use a LIOB 1064 with, in this case, not 9x9, but I'm using 5x5 gentle. Okay, LIOB using, let's say, -1 or -2 to create this micro damage, gentle micro damage to the melanocytes. And what energy I use usually 2.4, 2.8 with the MAQX, and with the PQX 1.6, 1.8. Okay, and do gently immediately after that exercise. Apply clobetasol. Okay, don't wait to see the post-inflammatory hyperpigmentation. Be aggressive immediately.
Okay. So you're saying you will use like a fractal method.
Yes.
For the MAQX, for example, with the FS20, 2.4 to 2.8 joules per pixel.
Yes.
Like a light form. This, you do that before the 532 or after the 532?
I do this after.
After, okay. This to create more micro damage of the lentigo. Okay.
Yes.
Okay, fantastic. Okay, we welcome any final questions from the floor, perhaps? No. Okay, Prof Marini, I think all the questions for tonight. If any of you have any questions, don't hesitate to reach out to me. I will pass it along to Professor Marini to answer your questions. But before we end tonight, Professor, is there any final thoughts that you have to leave behind with our audience? Any final pointers?
Yes. The final, the final message, take-home message is to understand what you have in your hand.
Okay.
I hope that it's clear that in your hand you have a Q switch system. Q switch system is a category of lasers that are able to emit a specific energy in a very short amount of time. And when we talk about Q switch system, we can talk about nanosecond, picosecond, super picosecond. They're all Q switch system.
Right.
Don't make, this must be clear, because otherwise, you get confused that this is a Q switch, this is not a Q switch. All this kind of laser are Q switch. Okay. And with Q switch, as I explained during my lecture, you have the possibility to have a photoacoustic disruption or a photoacoustic biomodulation according to the energy that you use. This is important. And the rule of the thumb is the same for conventional laser and non-photoacoustic laser, Q-switch laser. We need, in order to have this kind of energy conversion, you need to have a target, and the wavelength identify the target. And then according to the pulse duration, you have a different kind of effect. When you have this in mind and you have a tridimensional, picture of what you're doing on the patient, and you analyze the patient, you are in a good, kind of safety mode. Otherwise, you are in danger, even if you have the Rolls Royce of lasers in your hands.
Sure. Thank you, Prof, for the final important note as well. And just for the audience, we would just like to appeal for your kind help to help us fill up a very short survey form that you have in your portal to help us, to give us feedback and pointers of improvement for our next round again. But once again, thank you, Professor Marini, for your valuable time and very valuable and advanced insights for us. And for the tips that's being shared tonight and experiences as well. And thank you very much for our dear audience for taking up your valuable time, giving your valuable time to joining us tonight for our masterclass today. To the next time, we look forward to having all of you join us again. And thank you, Professor Marini, once again. Good night, everyone.
Thank you. See you next time. Ciao.
Ciao, ciao.